Or, like I said, I may decrease your insulin dosage in the evening. So you can do one of those two things to manage the patient. But both of those things result in morning hyperglycemia, so blood sugar is high in the morning. All right. Then on our neuro side, we got the things that we're looking at for patients, or kind of thinking about. Make sure you look at the assessment chapter. That's one of those highlight kind of things. Think about what things you're going to do as far as being assessed a neuro patient. One of the things I told you from when you started nursing school, always go see your patient. Do an assessment on your patient, especially with neuro stuff. Those little subtle changes sometimes can mean a big deal, but you got to know when they happen to the patient, because that can mean a difference as far as what you're going to do as far as treatment for the patient. So doing a neuro assessment on the patient, knowing how you do those things, important. I'm not going to ask you all those cranial nerves kind of thing. So you don't have to remember on old Olympus towering tops kind of stuff. All right? But you got to think about what you see with that patient. All right? Now, one, you will know, the thing you do have to kind of remember, not saying you got to recite them all. Pupil response is always going to be there. So that's part of the cranial nerves you have to look at, looking at pupil response for your patient. And always think about everything is supposed to be working together. So when you see no movement on one side, something is definitely happening somewhere in the head. Okay? So make sure you look at that. Look at the Glasgow Coma Scale. Look at some of the general testing that we use for patients. So look at the MRI, the CT scan. Because those are things that are going to be happening when you talk about head injuries. They're going to be things that we look for with hematomas. So there's a lot of other stuff as far as neuro testing, but by far those are the things we use most often. So the first section I have up here is infection. So those things that happen to a patient have to do with some type of infectious process. Meningitis is inflammation of the meninges or bacterial or viral infection that happens there. Bacteria, those are patients that you cannot take care of as a student. So you know how the nurse has to intervene sometimes when people are doing things crazy? Like using clean gloves on burn.
Oh.
Treated as sterile.
Oh my goodness.
So nurse has to intervene when certain things happen. Meningitis is one of those things that no student can take care of that patient. Or if the question says that a person goes in that room without a mask, because remember, bacterial meningitis is droplet infection kind of thing. Everybody who was close contact with somebody who had meningitis is treated. Okay, so one of the things you think about, meninges, meningeal irritation, what happens to your patient, what they're complaining about. Rarely do you see a person who has meningitis get increased intracranial pressure, but it can happen. Okay? It does happen to a patient. If you have a person who has signs and symptoms of increased intracranial pressure, they do not get a lumbar puncture. Okay, so LPs are routinely done. We try to, you don't need to do them, but a lot of doctors still do them for patients who they suspect have meningitis. Because if a patient has signs and symptoms, you need to just let it go kind of thing and treat the patient. Most patients that we treat are bacterial. You can have viral, but most patients we treat are bacterial. If you get a lumbar puncture on somebody who does have bacterial meningitis, CSF is cloudy. So that's kind of one of the things that gives it away. Viral is clear. So those are things that you kind of look at with the patient. But patient has meningeal irritation, so some of the things you see is neck rigidity. And if you try to flex the person's neck forward, because that causes pain in the patient. They may have photophobia, so things bother them as far as seeing. They'll tell you they have visual changes, those kind of things going on with the patient. They may have a headache, because all of those things are happening with your patient who has meningitis. Treatment is going to be antibiotics. For bacterial is most common. Viral really is symptomatic. So in your head, because bacterial happens most often, read that one. Because that's what the questions are going to be about. Viral is only treated symptomatically. Meaning if we can't find any reason your stuff is clear, then all I'm going to do is treat you for a headache and let you go home. But bacterial needs antibiotics. Patient goes on either type. When they don't know what it is, patient always goes on isolation until we figure it out. They treat close contacts. So think about people at risk. We do have a vaccine for this now. So you want people to do that. All right, so especially with teenagers, anybody that lives in a congregation type place, so people going off to college, you really want them to get the vaccine. But those are kind of things it's teaching. You kind of think about what's going on. But if you have a patient who has meningitis, they're treated under isolation. Bacterial is the one you're looking at, so that patient gets antibiotic therapy. Always, always. Everybody who's close contact, meaning family members, if that person was in school, people in their classroom will be treated as well. Because the issue that you have is that sometimes this kind of goes under the radar. You can have a person who has this and they end up dying from it. So you don't want that to happen with patients, especially when you're talking, a lot of it is kids. So you don't really want that to happen. Encephalitis is inflammation of the brain itself. This one tends to be more viral in nature. So it's the one that tends to be more virus related. We have outbreaks in our area every summer. Patients have encephalitis, usually coming from horses in our area. Okay, so they put chickens out in where different congregations or areas are. Chickens get bitten by mosquitoes and they see if they have encephalitis. That's how they tell where they're going to go spray for the mosquitoes. That's how it's transmitted. Okay, mosquito bites the horse, mosquito bites you, you end up with encephalitis. But it's viral in nature. The bad part about this one in particular is that patients can have cognitive decline associated with it. Meaning that you have people who are with it who are now crazy. I shouldn't say crazy, but they forget how to do stuff. All right. So you can have a person who was doing all their regular stuff in life who now forgetting what a spoon is. Kind of thing that can happen with encephalitis. So you don't generally have that with meningitis. It can happen, but it tends to happen more with patients who have encephalitis. So it can be fatal. It is a viral illness, so it's treated symptomatically, but by far, those patients who end up having it can end up having a lot more problems because of the cognitive piece that goes with it. Doesn't happen as often as meningitis. So just kind of look at encephalitis. Know it's viral in nature, treated symptomatically, but meningitis happens more. Brain abscess hardly ever happens. It tends to happen mostly in patients who have decreased immune systems. So HIV patients, or the people who are healthy, usually it's because they ingest amoebas in warm water kind of things. Because you have kids who have brain abscess who go swimming in these freshwater lakes. They figure out why does this person have this change in level of consciousness. They do a CT scan and they have amoebas in the brain. All right. Usually no cure. So whatever the cause is for this patient, they usually die from it, whether it be amoeba or whether it be from some bacteria. Because just think about it, you have cavitation that is happening based on either something that's a living organism or somebody that has a really bad bacterial infection. So they are usually fatal. Good thing they don't happen as often. You do have to look at closed head injury, so make sure you look at that. I don't ask you about whether it's a concussion or contusion, laceration, that kind of thing. But you need to think about what's going on when somebody has a head injury. So I just put closed head injury, traumatic brain injury, because overall, the umbrella is the same as far as management and care for patients. You're just talking about what ends up happening to them. Traumatic brain injuries can be things that actually have some type of outside access, but also can be from, because we talk about that in relationship to shrapnel wounds, that kind of stuff. A lot of things we talk about with that. But also closed head injury could be things that the person get hit by a baseball bat, or sometimes, because those are things that sometimes happen with patients. So think about in your head, the cranial vault, that is your skull. There's three things that are in there. Okay, there's brain tissue, CSF, and blood. And the thing about it is brain tissue doesn't really change unless you have a space-occupying lesion, like a brain tumor. Otherwise, you have CSF or blood that can go up and down so that you don't have pressure inside your head. Okay, if your body sees that there's too much CSF being produced, it will produce less blood. And vice versa. You know, the body does that. Only thing it doesn't change is your brain tissue. That's that Monroe-Kelly doctrine that they're talking about with that. Two science guys. All right, Monroe came along first, Kelly came in and added some other stuff to it. But there are people that are talking about those three things inside your head just have, you know, they're supposed to stay in dynamic space, and it's just supposed to be what's going on there. When you have something that happens in one of them that no longer can keep that in play, then you have a patient who has an increased intracranial pressure. So that's the end result of what ends up happening with your patient. But think about what happens when your patient has a closed head injury. You can have diffuse injury, meaning that the whole brain is injured, or you can have a focal injury, which means only part of the brain is injured in the patient. The good thing about it is we have so many cells in your brain, although there are days you feel like there's none. We really do have a lot of cells there, which is a good thing. But when you have patients who end up with those type, when we talk about these injuries, sometimes we don't know how bad it is until sometime later. And part of that is because the edema and swelling that happen after brain injury. So think about what happens, making sure you know how to test, making sure you look at that Glasgow Coma scale to see what we tell a patient, what are you looking at to see if there's some type of damage that's going on with your patient. And when you're thinking about head injuries, if it's a focal injury, you usually only get deficits related to what is working in the brain in that section. Okay, so if you have things with temporal lobe, you're thinking about here, because that's why going back and looking at what the lobes are responsible for kind of tells you what happens with your patient. So if something that happens in temporal, you're thinking about hearing, spatial kind of stuff. Something happened in the occipital lobe, you're talking about vision. Frontal is where your cognitive ability is. So think about those things that are happening with your patient. That's why you have to kind of look at that picture of the brain to see what's going on. Okay? But when we have patients who have injury, what we're trying to do is prevent them from long-term complications associated with that. And one of the things that kind of keeps that whole process going is when a patient develops increased intracranial pressure, or ICP. When that pressure is increased in the head, you're talking about greater than 20 millimeters of mercury for extended periods of time. Now, just for short time, it's not a big problem. Because actually, if we measured our own brains during times, because we do it all the time. Everybody in this room has had ICP at one point in your life, and you probably go like, oh, my head hurts. And I will tell you when you do it. You know, like when you have to sneeze, you try to hold it in, because you don't want everybody to go like, oh my God, what are they doing, sneezing all over me kind of stuff. Sometimes you sneeze so hard, you feel it in your head. And that's because the pressure for that momentary period of time goes really high, because you're trying to hold it in. The reason I gave you that visualization is think about those are things you don't want a patient to do who has ICP. So if you don't want them coughing, you don't want to put things that if you're suctioning them, minimum amount of suction on the patient, because remember, if they're coughing or they're bearing down, all of those things raise pressure in the head. So you're going to try to stay away from those. Sometimes you have to, because you have to clear airway on a patient, but those are things you're going to be monitoring to see what's going on with that. Always kind of think about what those things do. So if they're straining, you don't want them doing that either. So that means they get stool softeners, all that kind of stuff. When you're talking about people who have ICP, you don't want them bending over. That raises pressure in the head. All of those things you don't want them doing as far as when you're talking about care of the patient kind of stuff that's going on. Okay? But greater than 20 millimeters of mercury, and if it sustains that for a long period of time, that's going to put that person at risk for diffuse damage, and you're not being able to bring them back or salvage neurologic function. That's what you worry about. And you don't always have to put in a ventricular device, because you can put in a device to actually measure it. You're looking at the signs and symptoms the patient has. If I'm not seeing pupil response, I worry that they have ICP. If I have a patient who has projectile vomiting, because that's the difference with a patient who has ICP. Most of the time when you have people who have vomiting, they're nauseated. With ICP, they just vomit. And I can reach will in the back, kind of thing. That's how it is, projectile. So no nausea, but they have vomiting associated with it. There's a way you can actually look at a person without, you're looking at the symptoms that the patient has. But you can also look in their eye to see if they actually have increased ICP before you send them to an x-ray. When you look in a person's eye, you know that red reflex that ruins your pictures? That red, because that's light shining off the optic disc. So that's actually, that's where your visual field comes from, is that it's shining off, but it messes up your pictures, kind of thing, where you're making nice pictures or something. It always ruins it, okay? If you want to examine the patient's retina, what you're going to do is you get an ophthalmoscope. When you find that red reflex shining into the patient's eye, when you see it, then you're going to go in and look. That's what the doctor's doing when they do your exam. They look and find it, then they're going to come into your face, get really close, freak out. All right? But the thing you're doing with the patient is when you actually visualize the optic disc that's in the back of the eye, it's supposed to be sharp that you can see it, meaning that you see the borders that you can see them clearly. So that's what they're talking about, sharp margins. So that tells you there's no pressure inside the head. When you have a patient who has ICP, it looks almost like a beanbag, puffy, no sharp margins. This looks like if you laid in it, just marshmallow puff kind of thing. It loses that. That tells you there's pressure in the head, and what it's doing is choking off the optic nerve. That's what it's doing. So that's why you see this puffiness. So think about yourself. If you're seeing that, it's called papilledema. That is something that you can see without doing an x-ray. When you see that in a patient, that means there's pressure in the head. Projectile vomiting with no nausea, pressure in the head. Changes in the level of consciousness, pressure in the head. Decorticate posturing, deceberate posturing, because those things don't happen unless you have something going on in your head. Decorticate, bringing things to, so the patient looks like this. Deceberate, when you see them, they're pushing things out. So the cord, bringing things to, that's how you can remember them. Those are posturing things that are happening because something is going on in your patient's head. How we have to get rid of that, of course, is look at the underlying cause. And then we're going to give them some medication. Okay, so diuretics we need for this one. But we need a special one. We need an osmotic diuretic because most things that are going on in the head have to do with fluid, water kind of thing. What you're thinking about with this patient. So mannitol is a drug of choice. Okay, so mannitol is a diuretic. That's what you're going to use to actually treat this patient. It's going to help remove fluid, help lower pressure. Now, if I did put a catheter in the patient's head, when inside somebody's head, what is going to be my risk that I do that? If I put something in the ventricle, what's going to be my risk?
Infection?
Infection. They can end up getting meningitis because you put in a ventricular catheter. So anytime this person has a TIMP, treat immediately. You look for signs and symptoms of meningitis when they develop a TIMP. Could be from some other reason, but if they have a ventricular catheter in place, you automatically go there. So what I want to make sure this person does, I want to reverse this, keep the pressure as low as possible, hopefully maintain brain function. Okay. Seizures actually also cause this to get worse, so patients go on medications like phenobarb, Dilantin, Ativan is one. And when you're having an active seizure, it's Ativan and Valium you have to give to patients. But they go on some type of anti-seizure medication because all of those things increase oxygen demands of the brain, makes the patient worse. Some of the things that you'll see, because doctors sometimes use hypothermia with these patients as well, because that decreases the amount of blood supply needed by the brain. I can salvage tissue. So the other thing that we may see given to patients are steroids. Now, you know the whole thing about steroids. Steroids are not without risk. They can cause problems because they raise blood sugar, increase the risk of infection. But the other thing they do is decrease edema. So that's why you'll sometimes see them given to patients. But they can also cause avascular necrosis. So pain in your knees and joints may happen. Just saying.
That was going to 20
I saw that somewhere today.
All right, one of the other things that your patients can have as a result of something going on inside the head is what we call diabetes insipidus. It is not truly a diabetes. It has a lot of signs and symptoms that you see with diabetes, so that's why they call it that. More than anything, you see a lot of urine output. So when you have a head injury that puts out 100 cc's of urine this hour, 350 the next hour, 500, you think DI. It's a problem with antidiuretic hormone, which is the problem. You're not producing it. Patient ends up putting all these large amounts of dilute urine, causing hypovolemia. That's what the issue is with DI. So we have vasopressin we can give the patient to treat it. But you got to worry about electrolyte imbalances when you see DI happen. But it can happen with head injuries. It can also happen, it happens more when you have a patient who has surgery for tumors, but it is a complication that you sometimes see with head injury patients. So always think about large amounts of dilute urine, you think DI. Okay, that's what you got to think about. Because you know there's some other types. You may have talked about it in psych. There's a psychogenic one that is crazy. Those are people that drink water from anywhere, including toilets, because the urge to drink is so great. Madness, but you must. Just drinking out of the toilet is wrong. All right? It's wrong on so many levels. But they don't see it that way. It's a psychogenic piece that goes with it. All right, but those are things kind of think about, and I will send out another little review sheet about stuff you need to look at, make sure you know. Spinal cord injury is just that. That you have injury to the spinal cord. I'm not going to get into the partial things like Brown-Sequard syndrome, all that kind of stuff, because those things actually describe patients who have, you may have a person who still has sensation and no movement, or a person that has movement and no sensation, because those are partial syndromes. You're thinking about somebody who can't do jack, cut through kind of thing. That's what you're thinking about. In your head, think about what is going on with your patient, with the level of injury that's you got to worry about. So anything that's cervical, you're talking about from here to the neck, you got to think about airway, meaning that they can't keep their airway open or sustain or keep it themselves. And when you're talking about levels of injury, most patients who have 3 are dead. Okay, I'm just saying. And so think about when you're thinking this person can't maintain the airway. When you talk about thoracic injuries, you're talking about patients who have issues with developing pneumonias, that kind of thing. The other complication that tends to happen there is patients who have injury at T6. What sits right in front of it?
Heart.
The heart. So that's the person that has autonomic dysreflexia. We talk about T6 and right in this area, because that cardiac accelerator nerves come off right there. And so those are patients who end up having that problem. When you think about things in the lumbar area, sacral area, you're talking about bowel and bladder kind of stuff happening with your patient. So those are the kind of things you're thinking about what's going on as far as what's happening with your patient. But you're talking about an injury where there's going to be flaccid paralysis, for me, that you're talking about what happens with your patient. So think about level of injury, what you're going to see in the patient. You know, cervical, I got to worry about airway. Even if you have a patient who has something at C9, okay, think about what's going on with that person. Injury means that you have some type of damage that happened to the patient, and a lot of times it's young guys, that's people that most often have spinal cord injuries. It can happen to anybody, but it tends to happen to young guys because they do crazy things, all right? They really do. They jump off of stuff and not knowing how deep it is, or you jump down into things not knowing how deep it is, or you're doing stuff that's on that show Jackass and all that kind of stuff. People do stuff, you see things, people are like, what is wrong with these people? Doing these things to themselves, but they do stuff. And don't get me wrong, girls do it too, but by far you see young men get hurt most often. So this person gets injured, when you're talking about a person that has a C7, C9, whatever it is, that injury can actually extend because of the damage that's happening with inflammation and swelling. So that sometimes you can have a person with a true C9 who ends up being a C7 because we didn't start treatment early, they may have moved them around, whatever it is that we did to actually cause damage to happen with the patient. So that's why I'm saying, even if you have somebody with, if you're talking about farther down in the cervical spine, which means they should be able to do things with the upper arms kind of thing, as far as rehab goes, you're worried about this person maintaining their airway because of the extent of injury that can happen after the fact. Because there's some changes that happen. Oxidation is going on the nervous system. Patient ends up losing that, and the swelling and edema that happen after the fact can end up causing an injury that is higher than was the actual injury for the patient. Okay, so that's what you have to kind of think about what's going on with that. Major thing when you have a person that has spinal cord injury, stabilize the spine after the person is injured. So if somebody rolled in a truck, they're putting a collar on the patient, they're putting a backboard on the patient, stabilizing everything because they don't want you to move anymore to cause damage. You're thinking about the person, like I said, with a total total injury, meaning there's severing or there's not going to be any function. There's none of the syndromes that go with that. So what you're going to think about is where this person will have a level of paralysis. Okay, because when they come in the hospital, even though you're managing them right now, you're always thinking about where's the rehab potential for this person. The more function I can keep, the more likely this person can get up and actually do things for them. I shouldn't say get up, but be able to do things for themselves. Because even with fingers, people can push a wheelchair or use controls to move a wheelchair as opposed to somebody not being able to do anything. So that's why they always look at that kind of stuff that's going on with the patient. So what we're going to do is that initially you're going to see a lot of different things used for a patient. Steroids are controversial here as well, but we use them for patients. You also see patients use ice saline. That's one of the things that came out of actually a patient, it was something that was tested at a hospital in Detroit after a football player got hurt. And so now you see ice saline used around the spinal column to decrease inflammation, decrease swelling. And so you have some patients, because he was a patient that was hit, and you pretty much can tell when a person is totally knocked out or that something wrong happened. And this particular guy was a football player for the Detroit Lions. And when you saw him fall, you knew something was wrong. Because when people don't try to break their fall, like Aaron Rodgers did this week, if you saw that, it was like, I was hurting for him. Because when he went down, I was like, it's gone. Whatever it is, I thought he actually fractured both the bones in his arm, but he actually fractured the clavicle, which was the better of the things to happen. But the thing is, you can almost tell that something is not right. And he just went flat. This guy who's like 6'6", big old dude, just goes flat. When you don't see people trying to break their fall, you know something bad happens. So he did that, and he was one of the first patients in the country that they used ice saline around his spinal column, and he actually ended up walking out of the hospital. Months later, of course, in rehab, when you first see him walking, he's walking like Frankenstein, but at least he's up and walking. That's the kind of thing that's going on. The other thing we have now, of course, we have the whole controversy about stem cells going on, about whether or not that, because stem cells are the only cells in the body that regenerate new tissue based on whatever you put them in, because they can differentiate into anything. And so we have this whole controversy about whether we should use them or not. Everybody thinks people are mad scientists all over the country, just getting stem cells like everywhere, but there are really only 4 stem cell lines that exist. If people are doing stuff, it's really like black market kind of thing. There's only 4 places that actually you can get stem cells from indeed. But they show promise in that if we put them into the spinal column or wherever the patient has a neurologic injury, that they create new nerve cells. We have nothing else that does that. We talk about it, but those are things that people are kind of, when you see people fighting about stem cells, that's what they're talking about. It's because they can differentiate to new tissue that doesn't have disease. So that means that you can have people who are walking. And I will tell you, for me, why that is so significant, I mean, no matter what you feel about it, because there's a lot of people that are on religious reasons they talk about this, but when I was in nursing school, I did my neuro rotation at the VA when the spinal cord unit was brand new. And all I did every day was take care of young guys who could not walk. And I just, every day that I went there. And of course, they all had trays. So you know I was about to die about that anyway. But even going back now with UT students, it's the same thing. And I see people pushing their sons and daughters around with traumatic brain injuries. Could we not have people who are themselves again, as opposed to, being dependent on other people? There's a lot of stuff on either side, and that's something we're going to debate, I think, for the next 50, 100 years. I'll be dead and gone, for sure. But the thing about it is, that's quality of life for people. So there will be, even for you talking about kids who have seizure disorders where they're seizing all the time, and even the medical marijuana is not working. Could people now have a child who can actually have a full life when they grow up? There's a lot of stuff out there on either side. But the thing about it is research is showing that that's what helps people with neurologic disorders. Can we cure Parkinson's that way? So there's a lot of stuff that's going on either side of that. But spinal cord injury is one of those places where they're looking at a lot of research and are doing things with patients as far as getting mobility and those types of things that are going on. So you're thinking about the initial phase of what you do for this patient. Always think about ABCs. Think about the area where the patient has the injury, because it's going to kind of dictate what we're doing as far as their treatment. Look at complications. If you're looking at short term, I'm not talking about contractures and all that kind of stuff that happens later. Know that autonomic dysreflexia happens to people T6 and above in that area when you talk about injury. What usually happens is the patient actually has either a full bowel or bladder. That's the underlying cause of why this happens with your patient. But also think about skin stimulation as being one of those things that can cause that as well. Because full bowel or bladder is easy, meaning the catheter is usually kinked, or the patient needs a self-cath or whatever, however you're doing it, because that means the bladder is full. And you're going to see a patient who has complaints of a pounding headache, they get flushed, and you see redness associated with it. They tell you, my head is killing me, it's pounding, blood pressure is high, like hypertensive crisis. You got to look for why it's happening, and it's usually going to be the bowel or bladder. So empty the bladder. If it's the bowel, you may have to do a disimpacting the patient, because that's part of the long-term care is that patients go on bladder training, bowel training, so they're always having bowel movement so this doesn't happen. But during the acute phase, it may happen to the patient. Because remember, we use pain medicine to control pain, but most of those are open. So if you're doing that, that's going to cause constipation. So it can happen in those patients. So think about the people at risk for that going on with that. And what you want to do is, when you have a person that has this, you want to raise the head of their bed. Look for it. You still need to look at for whatever reason they have it. Empty those things. But the other, I was telling about skin stimulation, it can be something as simple as the sheets being wrinkled up under them, or you know how sometimes you may give a person an insulin injection and the cap goes off in the bed and you leave it there, you don't know where it went. Oh, you'll pick it up later. If a patient is laying on it, that stimulation can actually cause autonomic dysreflexia. So bunches of covers, because that's one of the things when they tell you to take about spinal cord injury patients, make sure everything is smooth in the bed. Because if stuff gets bunched under them, their skin is stimulated, so that actually causes this reaction to happen as well. Okay, so those are kind of things you need to make sure you're looking at for the patient. Then on our vascular side, we have our AVMs, and I don't really ask you about that one. You know, it's just telling you there's a malformation that's going on between the arterial and venous system. I do ask you about aneurysm. Usually that's the outpouching, just like you do in the vascular. If you're talking about a patient who has aortic aneurysm or thoracic aneurysm, it's the outpouching that happens there. It's the outpouching that happens in the head. And usually if this is going, it's long-term kind of thing for most people. But it's the vascular system has an outpouching. The vessel wall gets thinner over time. It's going to be susceptible to things increasing pressure in the head. So if you have hypertension, that's not a good thing when you're talking about a patient who has aneurysm. When you got a person who has an aneurysm, they're coughing, sneezing, all those kind of things, not a good thing happening to the patient. But the thing that kind of gives it away is the patient tells you I have the worst headache I ever had in my life. When you have people that tell you that, that is ominous, because that's usually what it is. Now I talk about it because I have headaches all the time. But when you say this is the worst headache I ever had in my life, and it's usually people who never have headaches, it's usually asymptomatic until the patient has a problem. But when they do, it's very bad because it ruptures and then you just have bleeding into the brain. There's not a lot you can do to stop the bleeding that happens. That's the problem. If you have a patient who is in a hospital that has a interventional radiology, that person goes down and they get coiled. That's what usually happens to those patients. But sometimes what you'll see is patient complain of morning headache, and they continue to keep complaining about it, so doctor ends up sending them for a CT scan and we find it. That's the good thing. That's the person who goes and gets this coiling done before it actually ruptures. If it ruptures in a patient, you may see change the level of consciousness, all those things that happen with a patient who has increased intracranial pressure, because remember, this is blood just going freely into the brain.